Chapter 6. Drug acting on the central nervous system. Drug acting on the central nervous system. General introduction. By far the most complex of the biological system is the central nervous system, CNS, which controls all activities of the body, including behavior. Basically, the CNS work on the principle of reflex action. It receives information, integrates this, and executes to the best of advantage to the body. Thus, there is a sensory input, central integration, and an efferent output. The efferent output may be in the form of neural impulse to various parts of the body, or hormonal release to adjust the body to the external environment. A multitude of neural systems exist within the CNS to accomplish the role of regulating body functions. While the transmission of message through the nerve is electrical, the transmission between one neuron and the other at the synapse junction is chemical. The neurons are named after the chemical transmitter at the synapse. Initiate the postsynaptic event in the peripheral nerve. Acetylcholine and noradrenaline are the main neurotransmitters. However, in the CNS, numerous chemical neurotransmitters have been identified which subserve the transmitter function at different synapses. The transmitter act at specialized sites known as receptors, which are specific for the release chemical substance. These receptors are the most vulnerable site for drug action. Acetylcholine and monoamine, while noradrenaline, adrenaline, dopamine, and 5-hydroxytryptamine 5-HT are now established as neurotransmitters at certain synapses within the CNS. Besides acetylcholine and the monoamine, histamine, the amino acid gamma-aminobutyric acid, GABA, glycine, glutamate, and aspartate are now accepted as central neurotransmitters. The demonstration of neurotransmitter properties of polypeptide has opened a large field of neurochemical substances which may function as putative transmitters in the CNS. To this category belong the enkephaline, endorphin, the angiotensin, oxytocin, and vasopressin, and other neuropeptides. Since the CNS is responsible for the control of autonomic, somatic, and psychic functions, it should be possible to alter each brain function by manipulating the receptor activity. Anesthesia is a reversible process by which loss of sensation in a body part or in the whole body is induced, usually by the administration of a drug that depresses the activity of nervous tissue either locally or generally. Purpose of anesthesia. The purpose of anesthesia is to provide a safe, convenient, and inexpensive means of restraint to enable clinical procedure to be performed with the minimum of pain, discomfort, and toxicity to the patient and anesthetics. History of anesthesia. Various techniques to induce unconsciousness have been described in ancient literature. Ancient Greek were aware that pressure on the carotid artery would induce unconsciousness. The surgeon pair adopted this method for inducing anesthesia. Drugs of various kinds have also been used for many countries to reduce the distress of surgical operation. Arabian physicians used drugs like opium and henbane. Alcohol was also used to dull sensation during emergency amputations performed in wartime. Strong rum was often administered to the patient. A brief account of a history of anesthesia is given below century-wise. 16th century ether was discovered. 17th century Christian Christopher Warren and Robert Boyle induced necrosis in a dog through intravenous injection of opium in 1665. 18th century nitrous oxide was discovered by Joseph Priestley in 1776. Humphrey Davy inhalated nitrous oxide and found that it produced euphoria and breath in 1799. Later discovered its anesthesia effect. 19th century morphine was isolated and pure drug was applied by sacrification in painful condition in 1806. Benjamin Brodie demonstrated the anesthetic properties of ether in 1821 but did not report it till 1851. William Sewell, a professor at the London Veterinary College, treated 2 cases of equine tetanus in 1835 using cureres. Nitrous oxide contained in bladders was passed around and inhaled for its soporific effect at particles in Britain and United States in late 1830s. Traveling show also used the myth-provoking equality of the gas to attract audiences. The U.S. dentist Horace Wells conceived the idea that nitrous oxide may be used for teeth extraction after watching a demonstration at one such show. Crawford Long, a U.S. physician, operated on a tumor on the neck of a friend under ether anesthesia in 1842. A ledger entry was used to establish his priority as the first man to use an anesthetic for a surgical operation. So the credit for this is often given to the person who demonstrated it in public. Well demonstrated that nitrous oxide could be used as anesthetic during teeth extraction in 1844 but kept in a secret. Thomas Morton, on October 16, 1846, was the first person to demonstrate ether anesthesia in public at an operation held at Massachusetts General Hospital. In the same year, 1846, armed with the knowledge of the use of diethyl ether in the U.S., British physician John Snow devised an apparatus for controlling its administration. He is also credited with classifying the stage of anesthesia into 5 stages. The Scottish obstetrician Y.J. Simpson was the first to administer an anesthetic diethyl ether for obstetrics in 1847. Later, they used chloroform for the same purpose. There was stiff opposition from the British clergy and others to the use of anesthetic during childbirth. They regarded painful childbirth varyingly as God is will or as advantageous to the patient or both. The first report of veterinary anesthesia was published in the Veterinarian. British practitioner Edward Matthew described his experiment on ether anesthesia in dog and cat. Snow's administration of chloroform to Queen Victoria during the birth of her son in 1853 helped in overcoming religious and medical prejudice toward anesthesia. So, ice had been in use as a regional anesthetic for years. A true local anesthetic, ether spray, was invented by Benjamin Richardson in 1867. In late 1860s, American dentist J.S. Smith attended a show put on by one Gardner Colton, which was the some show which had given Well his inspiration. Smith took on Colton as a partner, and together the two apparently excreted nearly 4,000 teeth under nitrous oxide anesthesia. First surgical operation under nitrous oxide anesthesia was performed in 1868. By 1875, chloral hydrate was being used as a narcotic and anesthetic in the horse. In 1884, cocaine was used for eye operation by Carl Kohler. August Bayer used cocaine as a spinal anesthetic in 1898. 20th century. Procaine was discovered in 1904. Baron used prozine as a local anesthesia in 1905. Redgen demonstrated epidural anesthesia in horse in 1925. Bennett demonstrated it in cattle. In 1940, James Farquhar Hansen introduced the prevertebral nerve block. After World War II, many pain clinics were founded in countries like Australia, Canada, Denmark, and USA. Gerbersen et al. Described one such clinic in Malmö, Sweden, where a patient with a pain is referred after a diagnosis is made for nerve block therapy. The history of anesthesia, according to Smith Cohen, offer mute testimony to the regrettable fact that medical men sometimes have been loath to need the lesson of history. This is apparent from the time lag between the demonstration of the anesthetic properties of ether and nitrous oxide and their eventually adoption as anesthetic. The history of anesthesia also has its share of high-end drama. The Morton Wells and Morton Jackson imbroglios are a poignant reminder of the underlying pressures faced by researchers all over the world. Regardless of country or century, an account of the incidents during the time is provided in Smith Core, 1971. The use of nitrous oxide and ether during tooth extraction were experimented upon individually by several dentists and doctors in America. Crawford, Long, and U.S. surgeon had used ether in his practice in 1842 but did not make his findings public till 1849. In 1844 itself, the American dentist Horace Well had extracted teeth using nitrous oxide. However, during a demonstration at Harvard Medical School where Well was the published his discovery apparently as a practice joke, the student subject howled as if in pain and Well was laughed out of the arena. Thomas Morton, a dentist in the same country, is generally regarded as the person who convinced the medical world that general anesthesia was a practical proposition. Morton has been a partner of Wells and was apparently aware of his successes with nitrous oxide. He approached a chemist, Charles Jackson, for a substitute for nitrous oxide. Jackson suggested the use of ether. On October 16, 1846, Morton administered ether to a patient during a demonstration held at Massachusetts General Hospital and was given the credit of being the first person to demonstrate the use of ether anesthesia in public. Unsuccessful in his attempt to establish priority of discovery, Well committed suicide. Morton and Jackson also became involved in a controversy to establish claim to the discovery of ether anesthesia. Morton was apparently deranged as a result of this and died after plunging into a lake while in a frenzy. Jackson, anxious to establish his claim, issued a report on work apparently done by him. However, apart from being acknowledged as the person who gave the suggestion to mortem, he was discredited and later died in an asylum. Important term. Important terms. Sedative. CNS depressant drug decrease the normal activity of CNS. A drug which produces mild depression of CNS is termed as sedative. Hypnotic. The drug that cause depression of the CNS equal to normal sleep are called hypnotics. CNS depression equal to deep or profound sleep with can be aroused with difficulty in necrosis, and drugs employed for necrosis are necrotic. Example, opium. Depression of the CNS when the individual is completely unconscious to all the sensation and external environmental is anesthesia. Depression of CNS to cause death is called euthanasia, and drugs that produce this state are euthanasias. Any degree of depression may be produced with a particular drug depending upon the dose used. Therefore, the same drug may act as a sedative or hypnotic, necrotic, or euthanasis. Hence, dose of this drug is more important. Balanced anesthesia. Balanced anesthesia. An ideal anesthetic should possess potent anesthetic, adequate analgesic, and sufficient muscle relaxant activities. Unfortunately, there is no single anesthetic available which possesses all these qualities in adequate amount. Therefore, a combination of different drug substances such as anesthetic, analgesic, and muscle relaxant is prepared which give the above mentioned activities. Such combination is known as balanced anesthetic, and the condition produced after its administration is called the balanced anesthesia. For example, combination of barbiturates for CNS depression, pethidine for analgesia, and D2-glucuronine for muscle relaxation. Pre-anesthetic. Pre-anesthetic, not necessarily a CNS depressant, is a drug which is administered before the administration of general anesthetic to make the anesthesia easy and safe. The administration of pre-anesthetic suppress bronchial salivary and lacrimal secretion. Example, atropine, hyoscine, chlorpromazine, hydrochloride. In veterinary, the administration of pre-anesthetic makes the animal cooperative and docile. Because of the sedative effect of pre-anesthetic, the dose of basal anesthetic is reduced and thus reduce the chance of toxicity. Pre-anesthetic block the effect of vagus on heart and reduce apprehension and anxiety. Basal anesthesia. Basal anesthesia. Basal anesthesia is lighter level of anesthesia produced generally by pre-anesthetic medication. The patient becomes unconscious but is not sufficiently depressed for undergoing surgery. Pentothal sodium 5% solution and formaldehyde 10 to 30% diluted in normal saline solution. Local anesthesia involves loss of sensation of limited area. Regional anesthesia, loss of sensation involved in a larger although in a limited area in the body. Characteristics of an ideal anesthesia. Characteristics of an ideal anesthetic. The anesthetic should be safest. Anesthesia should be smooth, easy, and there should be quick recovery. It should be balanced. It should be least depressant to respiratory and cardiovascular system. It should be non-irritant and non-explosive. Preferably, it should not diffuse into the fetal placenta. It should not promote capillary bleeding and should be compatible with pre-anesthetic and other ancillary therapeutic measure, that is drug use after anesthesia. The anesthetic should be neutralized with non-toxic antidote so that the duration of anesthesia can be shortened at will. It should be non-explosive and stable during storage. Anesthetics should not produce any pronounced physiological change. Example, marked depression in BP, heart rate and respiration. It should be cheap. Unfortunately, we do not have all the characteristics in one anesthetic agent. So, in order to achieve the approximation to ideal drug of complementary. Theory of general anesthesia, mechanism of action of general anesthesia. Theory of general anesthesia, mechanism of action of general anesthesia. Many theories have been given to explain the mechanism of action of general anesthetics, but none of them is very satisfactory and no one explains the mechanism of action of all the anesthetics. The theories given pertaining to mechanism of action of general anesthetics are as follows. Lipid theory. The theory was advanced by Mayer and Overton. This theory proposed that there is direct relationship between the affinity of an anesthetic to lipid and its depressant action. Nerve cell and membrane contain lipid. Anesthetic is thought to gain access to nerve tissue by virtue of its lipid solubility. Higher the partition coefficient, higher is the potency of anesthetic. In other words, higher solubility in fat and lesser in water, more the potency. Wider variety of inhalation anesthetic obey this rule. Fallacies. This substance were examined in vitro with vegetable oil rather than with brain lipid and body fluids, alkaloids and many inorganic ions do not comply with the theory. Many lipid soluble substances are not anesthetic, rather they produce convulsion. It is now known that anesthetic interact with protein, Feather and Stone et al. Finally, above proposal explain only in transport of anesthetic to cell of central nervous system and not the mechanism of narcosis. Surface tension theory, absorption theory. Surface tension theory, absorption theory. Trimbe and Lilly proposed the anesthetic potency of the lower surface tension. Warburg proposed that the accumulation of narcotic agent on the cell surface caused alteration of metabolic process, permeability and neural transmission resulting into anesthesia element, and Wilson demonstrated that the nitrous oxide N2O, cyclopropane, halothane and cyclofoam lowered the surface tension at the fat-water interface. Cell permeability theory. However, Lilly, Loewe and Winterstein proposed that anesthetics cause a change in permeability of the cell of CNS. Change in permeability interfere with the ionic movement necessary for membrane depolarization. CNS reported that certain agents may physically stabilize the cell membrane by preventing increases in all permeability. Anesthetic agents penetrate cell membrane and physically limit cell permeability and thus establishes against depolarization, either chloroform and urethane. Diethyl ether selectively decrease the permeability to sodium ion. Many other inhalation agents have been shown to influence sodium ion across the throat, bladder, and frog skin. Increase in RBC permeability to glucose by carbon dioxide is inhibited by halothane. However, whether these changes cause anesthesia and indeed how these changes are produced remain unexplained. Neurophysiological theory. Neurophysiological theory. Chloroform, ether, and barbiturates have been shown to inhibit synaptic transmission in cat superior cervical ganglion and at the same time inhibit axonal conduction. It has been postulated that anesthetics inhibit ascending reticular formation, which is important in maintenance of consciousness. Some anesthetics, such as cyclopropane, have profound effect on diffuse thalamic projection system in brain, while the subject remain quite aware of external stimuli. Thus, the theory gives important information regarding the neural effect of anesthetics but does not propose a basic fundamental mechanism by which agents produce this effect. Colloidal theory. Colloidal theory. This theory was initially proposed by Claude Bernard and collaborated by Bancroft and Richard. The theory proposed that aggregation of colloidal in cell accompanies anesthesia reversibly and thereby allowing for recovery. This was derived from putting muscle tissue in chloroform. On a result, there was increased optical density of muscle tissue. Diethyl ether and halothane inhibit movement of prostoplasmic streaming. Physical theory. Physical theory. Attempts have been made to relate anesthetic potency with thermodynamic activity or the molecular size of the agent. Increased potency has been correlated with increased magnitude of the van der Waals forces that relate to molecular volume and at the reaction between molecules. Polling theory. Polling theory. Polling proposed that anesthetic agent can form hydrated microcrystals or clathrates with the CNS. This involves an interaction of molecules of anesthetic with water molecules in brain rather than with lipid. The formation of clathrates mainly in synaptic region increase the impedance of the encephalonic network of conductors. Since the clathrates are not stable at body temperature or atmospheric pressure, he postulated that they are stabilized by the charged side chain of protein or CNS solute. Miller theory. Miller pointed that anesthetic agent within CNS is able to orient water molecules around it similar to Porling's microcrystals but of smaller size and paradoxically termed in an iceberg. He postulated that gas-filled iceberg functional to decrease electrical conductance, stuff the lipid or other material within the membrane and plug the pores of membrane. This approach remains attractive but unproven because hydrated microcrystals formation take place at lower temperature, but experimental evidence is lacking as to its formation during anesthesia. Hydrate dissociation pressure does not furnish the best correlation between anesthetic potency. It is not possible to prepare hydrate of all anesthetic in vitro. Biochemical theory. Biochemical theory. Various workers have sought to explain anesthesia in terms of biochemical phenomena. It explains that anesthetic drugs act by modifying or interfering with process of synthesis, storage, release, action, metabolism of one or more of the neurotransmitters agent. Uncoupling phosphorylation explains the mechanism of action of barbiturates and states that there is decreased synthesis of ATP due to inhibition of oxidative phosphorylation process or enzyme by the anesthetic drug. The anesthetic agent may inhibit the normal activity of one or more of the enzyme of CNS involved in the synthesis of certain neurotransmitter agents. Clinical stage of anesthesia. Clinical stage of anesthesia. Clinical stage of anesthesia. The depth of anesthesia may be classified into 4 stages using the neuromuscular reflexes. First, stage of voluntary excitement or stage of analgesia. Stage first. Stage of voluntary excitement or stage of analgesia. Stage first. This stage being from the beginning of the inhalation to loss of sensation, excitement and struggling is the most characteristic feature. Heartbeat becomes faster and stronger and the respiratory is rapid and deep. Pupil is dilated. There is excitement and excessive salivation due to irritation of vapor. There is no change in muscular tone. There is analgesia without loss of consciousness. Sensory depression in horse. Strangling is more violent and voluntary breath holding may occur. Stage of involuntary excitement or stage of delirium. Stage second. Stage of involuntary excitement or stage of delirium. Stage second. This stage begins with the depression of cortical center with loss of consciousness and voluntary center. There is X-aggregated reflex, struggling or purposeless movement. The horse may neigh or dog may whine and whimper, emit small bark. Generally, impulse is rapid and strong. Blood pressure elevated commonly in the early part. The respiration is uneven in depth and rate and breath holding may occur. Mucous membrane is flaccid. The eyelid remain widely open and pupil dilated. Reactivity of the iris to light. Photomotor reflex is retained. In horse, nystagmus oscillation of eyeball in the orbit is characteristic of this stage but not in dog and other species. In dog there is vomition if not faster and muscular tone is enhanced. This stage is very short staying. Stage first and stage second are known as induction stage. Stage second has been subdivided into stage second A, second B and third C. Stage second A, second B are characterized by abnormal posture and behavior and hallucination in man. Stage second C is characterized by cataleptoid. Cataleptoid stage is a waxy type of rigidity of the muscles but animal remain in position of placement. This may extend to muscle twitching, CNS excitation, and convulsion. Ether and chloroform induce all stage first, second, third, fourth, and therefore are totipotent anesthetic, 100% anesthesia producing. Methoxyfuran, halothane, and barbiturate do not produce stage second, no excitement. Thus, they may be considered good agent for inducing anesthesia. Nitrous oxide and 2 and trichloroethylene do not produce stage third or stage fourth and therefore are called incomplete anesthetics, 50% anesthesia. Alpha chlorolase, isofuran, and N-furan do not produce stage second and stage third. Catalamine produce stage first and second, producing seizure and catalepsy. Surgery anesthesia stage third. Surgical anesthesia stage third. During this stage, the present action of anesthetic is extended from the cortex and the mild brain to spinal cord. Pain sensation, consciousness, and spinal reflex are abolished. Muscular relaxation occurs and coordinated movement disappear. Nearly all surgical procedures and animals are performed in this stage. Stage third is further divided in plane first, plane second, plane third, and plane fourth. Plane first and second are known as light surgical anesthesia, and plane third and fourth is considered as deep surgical anesthesia. Light surgical anesthesia, plane first and second. Major operations in large animals are performed under light surgical anesthesia. Respiration slow and regular and consists of diaphragmatic and intercostal movements. Pulse and BP are normal. Nystagmus may occur but at slower rate. Pupils become constricted. The corneal and palpebral reflexes are still present but show to respond to stimuli. The pedal reflex, withdrawal of limb on painful stimulation, disappears almost at the onset of stage third. Cuff reflexes disappear in plane second. The shoving and skin reflex also gone. Palpebral, corneal, and pedal reflexes are frequently present in all planes when barbiturate anesthesia is used. Muscle tone, which was normal at the beginning of this stage, decreases due to depression of ordinary postural reflexes. In horse, tail become flaccid and limb and penis often protrude from the seat. Cutting skin and muscle does not produce reflex muscular contraction. Deep surgical anesthesia, plane third and fourth. Deep surgical anesthesia, plane third and fourth. Plane third is used for performing operation in human being and small animal like dog and cat. Body temperature fall rapidly, hypothermia, all reflexes disappear, and the respiration is chiefly abdominal. The thoracic respiration is depressed and disappears in plane 4. The pulse becomes weak, the BP drop in plane 4. The eyeball becomes fixed. Muscle tone is too much decreased and completely relaxed. The patient becomes flaccid. Feces and urine may pass involuntarily. Closure of eyelid in horse indicates the approximate surface maximum of anesthesia. Medullary paralysis and death stage 4. Medullary paralysis and death stage 4. Vital medullary centers are paralyzed. There is respiratory arrest with fall in BP to the shock level. Heart usually beat quickly for some time after respiration cessation. Hypoxia worsens and cardiac arrest occurs within 5 minutes of respiratory arrest. Large animal cannot be resuscitated. Small animal may be resuscitated by artificial respiration. Preparation of patient for anesthesia. Preparation for anesthesia. Majority of operations are planned, however, emergency operations are non-planned, where little preparation is possible. The following preparatory measures before performing operation may be taken. Withhold food. Without food, the food is withheld for 12 to 24 hours before operation is to be started, because the presence of ingesta may interfere with free movement of diaphragm and can dispose to respiratory difficulty. Moreover, gaseous distension occurring from fermentation process may result in interference of venous return to heart in ruminant and non-ruminant. Vomition may produce hazard of mechanical pneumonia and can contaminate the instruments and operative field. Glucose infusion. Glucose infusion in toxemic patient liver is reinforced by glucose before operation. Urine test and hematological examination. Urine test and hematological examination. General consideration in escalation of anesthetics. General consideration in selection of anesthetics. General consideration in selection of anesthetics. General consideration in selection of anesthetics. The anatomical and physiological peculiarities of the species and breed involved, as well as the temperament and size of the animal, influence the selection of anesthetic agent. Dog and cat, either with basal anesthetic, barbiturates preferred. Care should be taken in case of brachycephalic dog when general anesthetics used, and especially when endotracheal tube is not employed. Packing gauge bulldog. Ruminant. Large for stomach with great amount of ingesta invariably present make use for inhalation anesthetic impossible. Therefore, local or regional anesthetics with hypnotics are preferred in ruminant. Fourth, chloroform inhalant, chlorhydrous magnesium sulfate, pentobarb for operation on foot and leg. Perineural injection. Local anesthetic is prepared in standing condition. Swine. Pentobarbital sodium combined with local and regional. Epidural anesthetic are preferred. Because of obsessed characteristics, general anesthetics are dangerous. The nature of operation performed, its size, duration, and location are necessary consideration. Example case: cesarean section in dog, barbiturates in not used because it will kill fetus in uterus. Capped elbow in horse. This is subdermal fibrosis which is deep-seated, and thus local anesthetic agent cannot be effectively infiltrated. Therefore, general anesthetic is used. Deeply seated abscesses in the area of pharynx nearby structure produce movement of operative site, and thus general anesthesia is preferred. Species susceptibilities. Opium and its derivatives are good in dog, but it should be avoided in cat. and unsatisfactory in other species. Barbiturates in horse are not prepared. Chloroform is not prepared in small animal because it produces respiratory and CVS failure, but it is good in large animals, particularly in horse. Condition of the patient: prolonged fasting depletes glycogen reserves in liver, thus reducing the ability of the organ to detoxify poisonous material. Phenobarb is avoided in renal pathology. Inhalation anesthetics are not employed in respiratory disease. Chloroform is not used in patients suffering from heart disorder. Legal responsibility. Legal responsibility exists in some countries such as Great Britain, where the Animal Anesthetics Act of 1990 required that certain operations be performed only under a general anesthetic. Pre-anesthetic medication. Pre-anesthetic medication. Pre-anesthetic is a general term that refers to the administration of some agent shortly before anesthesia is administered. Such agents are morphine, meperidine, methadone, atropine, or a barbiturate for small animals and chlorhydrate for large animals. The objective of pre-anesthetic are to contain the patient so that it is more easily restrained with minimum of danger to animal and veterinarian. To decrease the amount dose of the anesthetic agent required to produce the surgical anesthesia. To decrease the flow of saliva and respiratory secretion which might hamper the breathing. To protect the animal patient from vagal reflexes and cardiac arrest induced by anesthetics. Example of pre-anesthetics: barbiturates, thiopentol, IV, and then maintained on ether. Thus, induction stage pass and off without struggling. Disadvantage: excitement in large animal hordes and occasionally in human due to greater open tolerance to many dependent drugs. Morphine used in men and dogs. It is very good analgesic, reduce anxiety, cut down struggling during induction stage, and thus induction more smooth. Compatibility with hyoscine, depressed cough reflex. Disadvantage: constipation and urinary retention effect. Pinpoint pupil depression of respiration may also induce salivation and bronchial secretion. Emesis: its stimulant effect on smooth muscles may cause spasm of bile product or of the uterus. Polycypan. Pethidine or meperidine hydrochloride. Pethidine or meperidine hydrochloride. It is non-constipatory, depresses secretion, atropine-like effect, do not produce sedation of that extent as do morphine, does not produce emesis. Atropine sulfate. Atropine sulfate is produce anti-secretory effect, incidence of bronchial and laryngeal spasm blockade due to vaginal stimulation. Protect the heart from vaginal stimulation. Mild stimulation effect on respiration. Cut down post-operative vomition and pulmonary complication. Disadvantage: altered pupillary sign, mydriasis, and cycloplasia. Scopolamine and hyoscine, similar to atropine but may produce CNS depression. Excitement lessened, produce amnesia. Counteract the respiratory depression of morphine, superior to atropine as largest disadvantage, actors very rarely produce delirium. Tribromethaneavertine, tribromethaneavertine, used mainly as basal anesthetic in men for brain surgery, and it lowers the CSF pressure. It is also used in cats. 135 mg per kg, 30% solution per rectum, but replaced by thiopental. The main advantage is that it is very easy to administer. Disadvantage as disadvantage as given per rectum, one dose not known how much drug is going to be absorbed due to erratic absorption, and thus it may be dangerous. Tranquilizer phenothiazine derivatives are used. It potentiates the administration of barbiturates and other anesthetics, thus reduce the dose. It also reduces the apprehension. Anxiety is antihistaminic, antiemetics. Butyrofen, droperidol, and panthyl 50 = 1 is used as neuroleptic analgesic. Post anesthetic medication. Post anesthetic medication with morphine or meperidine may be indicated to avoid post-operative pain with disturbance of operation area by patient. On the other hand, sleep should not be too long, too deep, because of a greater opportunity for hypostatic pneumonia to develop. Post-anesthetic fluid medication frequently is indicated following surgery to compensate for fluid loss for the body due to hemorrhage, vomiting, diarrhea. Thank you.